afternoon. My name is Cindy Chin, and I became introduced to the Epilepsy Foundation in 2001 when my brother was diagnosed with epilepsy, and which led to my role as a volunteer here now. Our final speaker will be Dr. Chris Ransom, who will speak on the topic of psychogenic non-epileptic seizures. Dr. Ransom is an assistant professor at the Neurology of the University of Washington and an epileptologist. Thank you. I've been struggling with that word. With the VA of Puget Sound Epilepsy Center of Excellence. He holds both an MD and a PhD from the University of Alabama School of Medicine. Dr. Ransom also serves as the Epilepsy Foundation Northwest Professional Advisory Board. Please welcome Dr. Ransom.
Well, thank you, and I want to thank Kevin and Rusty for organizing this and all the hard work putting this together and asking me to participate. It's my pleasure to talk to you guys today about psychogenic non-epileptic seizures. So psychogenic seizures are an incredibly difficult condition for everyone involved, both patients, family members, and providers. They're difficult to diagnose, they're difficult to even understand, and they can be incredibly difficult to treat and manage. For this reason, part of my talk, I'm going to review some basics about diagnosing seizures, epilepsy, and other seizure disorders. And this content closely parallels the dialogue I have with patients. This situation is complicated enough as it is, so it's really important that everyone's on the same page and speak in the same language when we review these elements. So I'm going to show one picture of a patient. She signed a consent for use for teaching purposes. And again, I'm going to review the diagnosis of epilepsy and seizure disorders, how we do that, and then describe some of the characteristics and treatments of psychogenic non-epileptic seizures, define what these are. So what is a seizure? Most everyone has an idea about what this is, and it's always remarkable to me that nearly 150 years ago, Hewlings-Jackson had the insight to give a pretty good definition of an occasional, excessive, and a disorderly discharge of nerve tissue. Modern neuroscience can barely improve on that definition put forth by Hewlings-Jackson of an epileptic seizure as a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neural activity in the brain. And the key part of this is associated with abnormal electrical activity or patterns of electrical activity that we can record during electroencephalography. So this is just an example of an EEG recording during a seizure, a specific type of seizure, an absence seizure. And there's this appearance of a large amplitude spike and wave discharge that occurs before the onset of symptoms. And for absence seizures, these symptoms are quite subtle. There's just some eye fluttering, period of bland unresponsiveness. When that electrical abnormality goes away, the individuals are right back to normal. So this is an epileptic seizure. What's epilepsy? So epilepsy is a disorder of the brain that's characterized by an enduring predisposition to recurrent, unprovoked epileptic seizures, as well as some of the other neurobiologic, cognitive, and social consequences of this condition. So epilepsy is a disease of the brain, and seizures are only one of the symptoms. Epileptic seizures and epilepsy can be really challenging to diagnose because depending on where in the brain seizures originate, they can really reproduce anything that we're capable of experiencing or doing can be reproduced by a seizure. Some of these symptoms are obvious, some are almost impossible to recognize. On top of that, a lot of other conditions can mimic epileptic seizures. They can look for all the world like an epileptic seizure, but they're due to something completely different. And as a neurologist and epileptologist, got it, right, that's our job, is to sort this out. When people get referred to our clinics, is to sort out, okay, what are your symptoms and what's causing these and how do we treat you for these symptoms? So there's not a real long list for conditions that can cause transient, recurrent neurological symptoms. The ones I highlight in bold are what I refer to as the big three. That's the bulk of conditions that we see in our seizure clinics. They're epileptic seizures, syncope or fainting, and psychogenic non-epileptic seizures. There's some other conditions such as migraine or transient ischemic attack that can produce recurrent or transient neurologic symptoms. There's some unusual types of movement disorders that can look like a seizure. as well as sleep disorders and toxic metabolic conditions such as hypoglycemia or uremia can cause fluctuating levels of mental status that on occasion will be confused for a seizure. If we expand this list to include some conditions specific to children and infants, we would list inattention or daydreaming, very simple behavioral changes that can be mistaken for a seizure, stereotyped movements, even reflux or the Dread-Sanford syndrome sometimes can be mistaken for an epileptic seizure. So again, these are the things we're trying to sort out when we see someone that's having a set of symptoms. Usually seizures are very stereotyped with characteristic features. If you saw 5 of them, they would look almost identical one to the next. They're brief. Seizures that last longer than 2 minutes are unusual. They also have a very characteristic evolving pattern, a crescendo, decrescendo, that can involve repetitive movements. People often have pronounced symptoms after the event is over. And the worst thing about seizures, as many of you know, is that they occur sporadically, unexpectedly. So these are elements we try to tease out when we're evaluating patients. But there's many situations where, based on clinical grounds alone, despite our best efforts, we really can't make an accurate diagnosis. And to that end, we owe a huge debt of gratitude to these 2 gentlemen who are legendary figures in the field of neurology, Kiffin Penry and Fritz Dreyfus. And they were pioneers in establishing specialized units to record continuous video and EEG data to characterize individual spells. And this has been an indispensable tool for people that are treating seizures to really make the accurate diagnosis. So this is the first scientific paper published, as far as I'm aware, describing the results of video EEG monitoring. So what is video EEG monitoring? People are admitted to a specialized unit that's equipped with EEG equipments and a video camera, and they stay in this hospital room until we observe one of their spells. And we want to record their habitual spells, the events that they're describing happening at home, and through analysis of both EEG data and the actual behavior, the symptoms that individuals experience during the seizures, we can almost always make an accurate diagnosis. And this is really the gold standard to diagnose epilepsy and other seizure disorders. Since the advent of video EEG monitoring, we've learned a lot about the different set of symptoms that are characteristic for certain types of seizures. I'm not going to go through all of these, but temporal lobe seizures have a very prominent aura often with either deja vu phenomena or other psychic phenomena of fear or dread. They can just be unresponsive or have some purposeless movements. And at the other end of the spectrum, seizures that originate in the frontal lobe can be very unusual appearing. They can have a lot of really violent shaking movements. And those are the types of seizures that we occasionally mistake for psychogenic events. So I'm just going to share a case with you guys. So this was an 8-year-old boy who was referred, Rusty may remember this patient, referred because of uncontrolled episodes of laughter. They're happening at home, at school. He was actually being disciplined for these events. And then his mom observed that he was happening while he was sleeping. So she brought him into our clinic and he was evaluated. The mom was a physician. She'd actually seen dozens of these events, and we carefully interviewed her. Does he do anything else? No, he just laughs. Does he move one way or the other? Does one side of the body move more than the other? No, he just kind of laughs. So that's all we knew about these events, and he was admitted for diagnostic video EEG monitoring, where we recorded several of his habitual spells. And the results of this showed that he had an unusual type of seizure, gelastic seizures. They're laughing seizures. So this is an unusual and rare type of seizure. But in addition to the laughing, every event we recorded, he had very prominent dystonic posturing of the right side of his body, which was, for our take, was impossible to miss. And I bring this example up because his mother was a medical professional, had seen dozens of these, and she just, because it's a family member, these things are distressing, they're scary, and it's difficult to be a good observer. And that's one of the challenges that neurologists have in diagnosing these things. And again, that's why video EEG monitoring is often necessary. So the outcome of video EEG monitoring, I'm just listing a couple of published studies. And non-epileptic diagnoses are seen in about 18 to 30% of the cases are admitted to the specialized video EEG monitoring units. And the majority of these are psychogenic non-epileptic seizures. In our hospital at the VA, these are just numbers from the last few years. About 23, almost a whole quarter, nearly 25% of the patients that we admitted, we ended up diagnosing with psychogenic non-epileptic seizures. And that's not just in our VA, but if we compare the numbers to the VA Epilepsy Centers of Excellence as a whole, which are 16 sites throughout the country, our numbers are almost identical. Where they're, as a whole, we're diagnosing psychogenic non-epileptic seizures in 22% of our admissions. So this is a common condition that we see. So this is a picture of considered the founding father of modern neurology, Jean-Martin Charcot. He was a physician in Paris, and he really diagnosed and characterized psychogenic non-epileptic seizures. And this is a picture of him in a demonstration hall where he's induced a psychogenic non-epileptic seizure in this woman with hypnosis. Apparently, these were very highly attended events. They used to charge tickets for people to go in and watch Charcot examine these patients. So psychogenic non-epileptic seizures are an episodic change in behavior that can resemble an epileptic seizure. It's considered a type of conversion disorder. So what's a conversion disorder? The concept is that conversion disorders occur when there's some internal psychological or emotional stress that outstrips an individual's ability to consciously deal with it. And those stresses are then converted into a physical symptom. They're not associated with any abnormal electrical activity in the brain. And we believe that these are really involuntary events. People aren't doing this on purpose to get attention. They're not faking them. These things just happen because of these emotional stresses. And this is a complicated thing to understand. It's complicated for me to understand. It's difficult for patients to understand. I always give the example to patients that if they've ever seen someone who's nervous speaking in public, their mouth will get dry, like mine is a little right now. They can start sweating. They can start shaking. They're clumsy, knocking things over. They're not thinking straight. And so those are all very real, very observable, very involuntary changes in behavior due to emotional factors. And psychogenic non-epileptic seizures are, my view, is really at an extreme of that, where this is an inappropriate reaction to stress. So I just listed the DSM-4, which is a diagnostic manual, lists psychogenic non-epileptic seizures and conversion disorder under the somatoform disorders. So the terminology for these has changed over the years. In the past, including Charcot's day, they called these hysteroepilepsy or hysterical fits. They believed that this, because it was observed most commonly in women, that this somehow was related to the uterus. We know that's not correct, but that's just a historical perspective on where we've come with these things. And more recently, they've been called pseudo-seizures. All of these terms have fallen out of favor. They're a little offensive to patients. They contain a little judgmental quality, and they compromise the patient-doctor relationship. So many clinicians prefer to call these things non-epileptic spells or non-epileptic events. And that's what I try to do in my practice. I think it's unfortunate that the term psychogenic non-epileptic seizures has been used in the literature because it's really confusing to patients. You told me I didn't have a seizure, but then you're calling this a seizure. What do I have, doctor? But in any event, that's where we're at. It's a common condition. Estimated in the general population of 1.5 per 100,000, there's a much greater incidence in at-risk populations. And the greatest risk factors for these types of events are a history of physical or emotional abuse, traumatic life experiences, and in the veterans I see at the VA, the #1 risk factor is PTSD. Anxiety or mood disorders are a risk factor for having these types of events, as well as having a history of epilepsy. That makes it really challenging. Someone could have both epileptic seizures and then these other types of events. But that is a risk factor for developing these types of spells. Even having a family member with epilepsy can be predisposing to psychogenic non-epileptic seizures. As I mentioned, they are common, more common in women and men. We see them in pediatric populations. Children have them, and the incidence of these in children increases with age. And not only are these things unusual and difficult to diagnose, but the characteristics can be highly variable. Some people can have really dramatic, violent thrashing movements during their events, like in some of those pictures I showed you at the beginning with a woman really arching her back and her arms were tonically extended, to other events which are just characterized by bland unresponsiveness, kind of dissociation from their environment. A sizable number of the patients that we see in our epilepsy clinics and in our video EEG monitoring units, as I mentioned, are ultimately diagnosed with psychogenic non-epileptic seizures, up to 30 to 50% in some reports from authors. And the cost and healthcare burden of this is similar to epilepsy. These individuals use a lot of healthcare resources, and an example of this this was a study done by my colleague at the Portland VA. He looked at how long it took veterans to be diagnosed with psychogenic non-epileptic seizures versus a civilian population. And he found that veterans had a much longer interval to being diagnosed with psychogenic non-epileptic seizure, and a 4-fold greater exposure to unnecessary anti-epileptic drugs. As many of you know, anti-epileptic drugs are not benign medications, and so this is something that has contributed to the cost of caring for people with psychogenic events, and this is a trend we're hoping to correct with the establishment of these epilepsy centers within the VA system. So how do we distinguish between psychogenic non-epileptic seizures and epileptic seizures? Well, there's several historical elements that we look at. One is that anti-epileptic drugs didn't help at all. People continue to have events even though they're on several anti-epileptic drugs. They're not improved one bit with these medications. Events are consistently associated with a specific situation or activity. These types of events occur much more frequently in the presence of others, where epileptic seizures occur sporadically and unexpectedly. Psychogenic events very commonly will occur in the presence of other people. People that have, in addition to spells, a list of other medically unexplained symptoms is something that concerns us for the possibility of psychogenic non-epileptic seizures. And as I mentioned, we always try to probe for histories of remote abuse or trauma. And these individuals, their evaluations will be normal. Their brain MRIs will be normal. Their electroencephalograms will be normal. In terms of the actual characteristics of the spells for psychogenic non-epileptic events, they have a more gradual onset than we see with epileptic seizures. They can have very rapid recovery after the event's over. These individuals typically don't have the deep and significant postictal symptoms that individuals with epilepsy experience. The movements during these can be really undulating, kind of come and go over time, and the events last much, much longer than usual epileptic seizures do. They can also be partially responsive during the event. So the next couple slides, I have a couple tables showing some of the signs that are common in psychogenic non-epileptic seizures, comparing that to epilepsy, and then another slide showing some signs that are very common with epileptic seizures that you do not see with psychogenic events. So closed eyelid closure or eye closure at onset of the event, that's very common with psychogenic non-epileptic seizures. And I think it's something that anyone that's observing an event like this should be paying attention for. It's very rare with epileptic seizures. And in fact, epileptic seizures that start during sleep, one of the first things we see is that individuals will open their eyes. So that's a very useful sign that there's forced eyelid closure. Individuals can sometimes resist opening of their eyes during their events. As I mentioned, they can have a gradual onset and very prolonged duration. It's not uncommon for these types of events to go more than 10 minutes. They really have asynchronous movements of their limbs, which is something we don't see with epileptic seizures. There can be partial memory for the event, which is uncommon for epileptic seizures. And things that happen with epileptic seizures that are very uncommon for psychogenic events are emergence out of sleep, out of EEG confirmed sleep, is very common with epileptic seizures. Nocturnal seizures are frequently occur. That doesn't happen with psychogenic events. Tongue biting is unusual for psychogenic events. There's another thing that's, and after the seizure happens, for epileptic seizures, there's a very characteristic, very deep labored breathing. And if anyone's ever seen this, it's not something that you'll really mistake for something else. And that's not present with non-epileptic events. Once the event stops, they'll just be breathing relaxed. And so there's a lot of helpful signs that we can try to tease out when we're taking histories that can help us distinguish between an epileptic seizure or a psychogenic event. But again, the history is often challenging, and we're often not entirely sure until we see the event. And this is a quote from one of my mentors, and it may sound a little bit flippant, but I think it's not useful to everybody, but Dick Madsen, who was a former president of the American Epilepsy Society, when asked, how do you know it's a non-epileptic seizure? His answer was, because it doesn't look like an epileptic seizure. And that's because people who care for people with epilepsy and interpret video EEG have a very good understanding of what the spectrum of behaviors and signs and symptoms that occur during epileptic seizures are. And if you compare those to a psychogenic event, they're readily distinguishable. So this is another case. It's a 32-year-old woman with a generalized epilepsy syndrome, juvenile myoclonic epilepsy. Her seizures had been very well controlled on anti-epileptic medications. She hadn't had a seizure in 4 or 5 years. And I'd seen her maybe once a year. And then she started having a lot of more spells. She had events that she described as jerking. She had events where she described just blanking out. And then she had other events that she characterized as big ones with major motor activity and loss of consciousness. We advanced her medications, and she continued to have these types of episodes. So we admitted her for diagnostic video EEG monitoring. And the video EEG results, we recorded many of her spells. They're associated with ictal eye closure, so her eyes would close right at the onset of these symptoms. She had really writhing and undulating movements with back arching and pelvic thrusting movements, unusual for epileptic seizures. She had asynchronous movements of her limbs, and these would shift from side to side. It's something that we would rarely see with an epileptic seizure. And she was partially responsive during these events, which were often very long, up to 10 minutes at times. And on top of that, and this EEG recording may not be that meaningful to everybody, but this was a perfectly normal background EEG. There was no change in her EEG activity during these events. So this was a woman who we ended up diagnosing. She has epilepsy, but she also has these non-epileptic seizures, these non-epileptic episodes. And in her case, she actually did quite well. Taking additional history after we explained the diagnosis to her, she acknowledged that she had significant social stressors recently related to conflict with her husband about starting a family and struggles at school. And that led to a shift in her care to being referred to a therapist, and she was able to distinguish the two types of events, her epileptic seizures and these psychogenic non-epileptic episodes, which is always a real challenge. But since we were able to accomplish those things, she did very, very well. So how do we treat these types of episodes? First thing is establishing the diagnosis. And then you have to have a talk with the patient. And this is a difficult conversation to have, but it involves explaining what we've diagnosed them with, explaining that these events are not epileptic seizures. They often already know that trials with anti-epileptic medications were ineffective. And we reassure patients that you don't have epilepsy, this isn't a progressive neurologic condition, and we stop the anti-epileptic medications, which again have not been ineffective. If you see one in front of you, the goals are not dissimilar to what you would do for someone with an epileptic seizure. It's really keeping them safe, remove them to a quiet environment. Emergency department visits are not necessary for clearly defined psychogenic non-epileptic seizures, but for the school nurses here, that's often difficult to know. And so recognizing some of these signs and being able to distinguish these events is essential. Particularly because they're often protracted and prolonged and would be in the range of durations where we discussed earlier a rescue medication would be indicated. And an individual like this woman I described who had both epileptic seizures and psychogenic non-epileptic events, it's doubly difficult. Overall, these types of events are difficult to treat. They can lead to high levels of disability. Less than a third of individuals that suffer psychogenic non-epileptic episodes achieve seizure freedom. The things that improve outcome are early diagnosis. And the woman I spoke about, I think we did her a good service by getting her in quickly and establishing the diagnosis versus keep trying other medications. If these things are allowed to go on for a long period of time, these behaviors can become quite durable and very resistant to therapies. Having a benign psychiatric history or an identifiable trauma associated with these events can provide better outcomes. And again, the patient I described, I think she did have some identifiable stressors that we were able to bring up and present to her and work on, and that improved her outcome. Overall, this really requires a multidisciplinary approach to care for individuals with psychogenic non-epileptic episodes. They need mental health care, either with a psychiatrist or therapist, as well as continued neurology follow-up. And I think our job as neurologists is to continually reinforce this diagnosis and manage any other comorbid conditions in conjunction with their mental health providers. So we want to improve patients' understanding about their type of spells, help them generate insight to what they are and why they're happening. That seems to improve outcomes. Even if it doesn't control the events or these episodes completely, it can make them less frightening, less disruptive, and less problematic. They're less likely to go to the emergency department, for instance. We got to work to improve patients' problem solving and communication skills. That's something that usually they'll work with therapists and other healthcare providers more than the neurologists, but those are efforts that we always try to support and promote. And there's some hope for these individuals. There's some newer therapies, including a cognitive behavioral therapy program that's specifically designed to treat these types of psychogenic non-epileptic seizures. And the doctors that are using this have enjoyed some early success. They published a randomized, prospective, multi-center clinical trial showing that this form of cognitive behavioral therapy was superior to usual treatments in controlling psychogenic non-epileptic episodes. And we're excited that at the VA we have an individual who's providing these therapies to veterans. And for our school nurses, I have a couple of other slides that list some suggestions that were outlined by the Epilepsy Foundation for handling these types of events in school-age children. So one, it's important that the diagnosis be established. That's not something that you all would do, but that patients would see their neurologist and get an accurate diagnosis established. Once that's done, I think that a plan should be in place how to address these events, how to notify parents, and any information that can be provided to you, how to recognize the events as a non-epileptic episode will be really valuable. Many patients, in particular individuals that have epileptic seizures and non-epileptic events, if we can get them to understand the difference, that's incredibly valuable. And if someone's in a video EEG monitoring unit and we really understand precisely the characteristics of their events, those can be shared with family members to allow them to better distinguish the two types of events. Relaxation techniques, either meditation or visual imagery to reduce reactions to events could be helpful. It's appropriate to children that have these types of episodes to move them to a place to decrease their external stimuli. I think that allowing children to move to a quiet place if stress of the parent or events are happening is certainly appropriate. And this gets into some of the things that Dr. Johnson spoke about, whether there's a need for an individual education plan if these things become so disruptive to their school activities as well as the activities of others, or even a 504 plan for accommodations. And I think this top point is important for individuals with psychogenic non-epileptic seizures, is to really encourage prompt return to normal activity after these events. It's easy for most of us to anticipate that the perception of disability or sense of isolation and stress could be amplified if every time they had one of these psychogenic events, they're sent to the nurse's office for a prolonged period of time or sent home. So it's really beneficial to support them, get them to a quiet place where they can relax, and then have them return to their normal activities. Another point brought up by the Epilepsy Foundation is to working with children to develop and rehearse some talking points so they can explain their symptoms to classmates. And I think that's just as appropriate for people with epileptic seizures as well, because these are frightening, unusual, scary events, and helping children formulate a way to describe their condition is going to be really valuable. So in summary, epilepsy and other seizure disorders can be very difficult to diagnose, and it often requires an inpatient admission with video EEG monitoring to make the correct diagnosis. These psychogenic non-epileptic events are a very common condition. They involve involuntary changes in behavior. They're not associated with any abnormal electrical activity in the brain. And they have some behavioral characteristics that are important and allow us to distinguish them between epileptic seizures. Risk factors of prior trauma, PTSD, or anxiety or mood disorders should be recognized. And we always need to consider this in individuals who have been on a bunch of seizure medications and continue to have spells without any change in their character or frequency. A multidisciplinary approach is necessary to care for these individuals. Like I mentioned earlier, timely diagnosis is crucial, as well as education about their diagnosis and stopping seizure medications. We try to help them develop insight into their spells to make them less disruptive, frightening. And then there's some special considerations for school-age children, which involves an organized plan with teachers, nurses, and parents, and promoting some relaxation techniques for these children, and helping them develop a way to communicate their symptoms to their peers. So I'm really happy I got a chance to speak with you all, and I'm happy to entertain any questions.
Have the EEG video monitoring? Do you wait till they have an episode? What if they don't have an episode during that time?
Yeah, and if you notice that chart, the largest chunk of that pie was the non-diagnostic category. And most of those are admissions where we didn't record any of the spells, or we had some spells that just weren't of sufficient, didn't provide sufficient information to make an accurate diagnosis. But typically, at least at the VA, we have people stay for 5 days. And often people can stay for 14 days or more, depending on the indication for the study. So, we really have them stay in there. And in many instances, we keep them for, like I say, up to a couple weeks because we need to see the episode.
Do you have a kind of a guess of how comorbid the non-psychogenic are with epilepsy itself?
Yeah, I don't know that number off the top of my head, and maybe Rusty up, but I think it can be as high, and some authors have reported as high as 30% of people with epilepsy also have, or at least have had, psychogenic non-epileptic events. So it's a pretty common thing that we see. In our practice, I think we've seen over the last 3 years, 3 cases where they had diagnosed, confirmed epileptic seizures as well as psychogenic non-epileptic seizures. But in civilian practice, it can be much more common.
And then my other question is, would a VNS ever be indicated for non-psychogenic epileptic seizures?
Yeah, I was at a meeting a couple years ago, and my friend Steve Holloway asked someone if VNS would be helpful for these. There's no answer that I can give you for that, other than there is evidence that vagal nerve stimulation can improve mood, can maybe improve PTSD symptoms. So achieving that could secondarily improve the occurrence of these psychogenic non-epileptic episodes. But I don't know, do you know, I don't think it's ever been studied carefully, so I don't know. Yeah.
Just
That's
wanted to ask.
Go ahead. There was something up there about a 12-week cognitive behavioral therapy. What about for therapists who have never been exposed to PNES and they just have a regular treatment plan that without a lot of forward progress?
Yeah, and that could be beneficial. As you may know, there's cognitive behavioral therapy programs designed for many different conditions. The one I spoke about is really carefully tailored for psychogenic non-epileptic episodes.
Now, is that available to all therapists?
It could be available. So right now, there's a couple people that provide training for this. We have a neuropsychologist at the VA Puget Sound who is trained by Kurt LaFrance, who developed this program. And he had her go, we actually had to pay him for her to get the training, but he has trainees go through 2 beta patients, so do 2 12-week sessions with 2 different individuals. Those sessions are video recorded, and he reviews them with our therapist, Katie Pagalayan, and critiques her.
Okay.
And so that's how she got trained to perform that. That's not necessary, and he's published a manual for this. It's a very manualized program, and anyone could get that manual, read up on it, and start using this tool.
Now, has ACT, acceptance and compassion therapy, been helpful, known helpful at all for the?
You know, I'm not very familiar with that, but I think that some of those things could have benefits, yeah, and in terms of, like I mentioned, particularly for school-age children, promote anything that promoted relaxation and lowered stress, my bias would be beneficial. Again, these are very difficult to get rid of completely, and we often, even people that enroll in our CBT program, we inform them, we may never stop these things altogether, but we really want you to gain insight into them so they don't happen as much, and they're not as frightening, and they're not as disruptive to your life.
I appreciate you.
I'm wondering if you've noticed a pattern between trauma and onset in working with veterans. Is there a timing that you're noticing?
Yeah, I think it can be variable. We've seen it both ways, with a real acute trauma, and then these things happening within weeks. More commonly, we see these things manifesting maybe 5, 10, or even more years after some remote trauma. And I think that's true not just in veterans, but in civilian populations where remote, even childhood, physical or sexual abuse manifests later as these types of events. So it can be variable, but we have seen both with a really short latent period from a trauma to the appearance of these behaviors, and then sometimes it can be decades. It could be, yeah, and that's the hardest part, talking to people, because sometimes they're, well, there hasn't been anything, and what is this trauma that you're telling me is causing these episodes? And it's not always apparent, and that's where therapists and cognitive behavioral therapy is really valuable, because that digs deep into those issues. Yeah.
A place where we can find a listing of the therapists that do the specific 12-week program?
That's a good question. I don't know the answer to that, but I could give you I could look up for you, and I could certainly give you Kurt LaFrance's website, where he has a lot of information on the people that are doing this. We've had a big emphasis in training providers within the VA because we've been at war for well over a decade, and we see a lot of young soldiers come back with PTSD that develop these things.
I guess my question is more physiologic. So at a cellular level, what are you seeing as far as, I think when we think about PTSD, we immediately go to this classification of medications, but is there a physiologic level
Yeah,
that you're
and-
looking at? Because it just seems, what is disruptive, and is that cell bringing back a memory that it's flooding its system?
Right, and so the short answer is we don't totally understand these things, but I think it's easiest to, for me to try to answer your question thinking about the example you brought up of PTSD. We know PTSD is a disorder of hypervigilance. We all get a fight or flight response with an adrenaline surge and help us do things and handle a stressful situation. PTSD, the main characteristic is that vigilance response or that fight or flight response is out of control, and they go from 0 to 120 like that. And there's increasing biological data to support that. One that I can give you is that an effective drug to treat PTSD, one of the most effective drugs we use, is a drug called prazosin, which actually blocks adrenergic receptors, the same receptors that are stimulated by epinephrine or adrenaline. And so that's maybe one biological element that we kind of understand. But how that gets translated into these types of events, we simply don't know. And that's what's hard to talk about this with patients, because we have to acknowledge we don't understand these things. We can tell them our beliefs and our ideas about it, but we just don't completely understand them. Certainly not at the level of individual cells.
I was just looking for a clarification on one of the facts you were stating about psychogenic non-epileptic seizures. Earlier in the slideshow, there was a point that said that it increases with age. Did that mean that it's more prevalent among older
Yeah,
people,
and
or
I'll-
that it gets worse as you age?
Right, and I think I had that, I was specifically referencing pediatric population.
Okay.
So if you look at age groups, it's been documented in children as young as 5 years old. It's not
Wow.
common, but it happens. But if you kind of look at age group 5 to 8, and then 8 to 11, then 12 to 18, it goes up as you look across those
Okay.
age groups.
Like the initial occurrence, happens more frequently in older children.
In older children.
Okay.
It's more common in
Okay.
adolescents, teenagers than it is in school-age
Okay.
children.
But that wasn't to suggest a trend that the older you get, the higher the occurrence in an individual person.
No,
Okay.
no.
That's
Thanks, that's important to clarify.
Is it possible to get a copy of these slides?
Sure, yeah, I'm happy to.
They're going to
share.
be on our YouTube page, so you'll see the presentation.
Okay.
Yeah, I mean, we can maybe save it as a PDF and give them to you. I don't care. I mean, I'm happy to do that. I don't know if you could
Send
help.
it to me, and then
Yeah,
contact either Jessica or I, and we'll get it to you.
yeah, I'm happy to share these materials with anyone.
Or questions?
Thank you.